Okay, it's right around noon now, so we'll kick off this discussion. This webinar, as you know, focuses on the escalating COVID-19 crisis throughout Syria. I'm Kat Fallon, and I'm the Director of Policy and Communications at MedGlobal. As many of you know, MedGlobal is an international health and humanitarian organization working to serve communities with sustainable and innovative healthcare, particularly refugees, displaced people, and other vulnerable populations. We work in crisis-affected areas and low-resource settings with a focus on collaborations with local health organizations, and our mission is to create a world without healthcare disparity. So this webinar focuses on how COVID-19 has impacted people throughout Syria who have already faced over 9 years of an emergency conflict and a complete humanitarian disaster. As everyone on this panel knows far too well, the conflict has led to staggering levels of death and need inside of the country. It has decimated the country's infrastructure, in particularly medical infrastructure, and it's led to the world's largest displacement crisis. Violence against healthcare in particular, including the systematic bombing of hospitals and ambulances, the detainment and arrest of health workers, and the denial of health assistance to entire communities in Syria, has been a truly defining feature of the conflict. And in the last 9 years, with the changing front lines and different de facto authorities, different regions of Syria have been experiencing their own unique health crises and challenges. Going into February of this past year, civilians in Syria in many ways were more vulnerable than ever before, particularly following a massive wave of new forced displacement in the northwest, particularly in Idlib. And then, as we all know, the pandemic hit. In March of this year, there were first reports of COVID-19 in northeast Syria and in Damascus and in a few other areas. And then in July, the first case of COVID-19 was confirmed in Idlib in the northwest. And now the COVID-19 crisis in Syria has truly hit a tipping point. In the northwest, the confirmed number of patients with COVID-19 is currently 10 times higher than it was last month. And in Damascus, local medical professionals have described overwhelmed hospitals turning patients away and report that official COVID-19 cases are only a small fraction of the true scope. And throughout the country, there are low levels of testing and an acute lack of health workers. So the impact of the pandemic is adding now to the already dire humanitarian conditions. I'm very pleased to be joined by a very expert panel of speakers today who will be speaking to the COVID-19 situation and response around Syria in the northwest, in the northeast, and in Damascus and the surrounding areas. We'll be hearing from Dr. Zahar Sahlul, the president and co-founder of MedGlobal. We'll be hearing from Dr. Nasser Al-Mahawish, the surveillance coordinator for the Early Warning Alert and Response Network, or EWARN. Hazem Rahawi, the senior programs manager of the American Relief Coalition for Syria, or ARCS, and Tim Young, who is the Northeast Syria Forum emergency coordinator, who focuses on the COVID-19 response. And so before we begin, I would encourage webinar participants to type in any questions to the panelists that you may have as we go along. We'll be collecting the questions for a Q&A following the presentations by these four panelists, and we'll dive right into questions from the audience after that. So we'll start by hearing from Dr. Zahar Sahlul. Dr. Zahar is the president and co-founder of MedGlobal. He is a critical care specialist and an associate professor in clinical medicine at the University of Illinois in Chicago. He's the former president of the Syrian American Medical Society, the co-founder of the American Relief Coalition for Syria, and the co-founder of the Syria Faith Initiative. Dr. Zahar sits on the advisory board of the Center for Public Health and Human Rights at the Johns Hopkins University Bloomberg School of Public Health, and he's a member of the Middle East Institute Syria Program Advisory Council. This year, in 2020, he received the Gandhi Peace Award by promoting enduring peace for his humanitarian work in Syria, and he was the Chicagoan of the Year in 2016 for his medical work in besieged Aleppo. And Dr. Zahar was most recently in Syria in January of 2020, where he visited local humanitarian partners. He met with newly displaced people in IDP camps, and he treated patients in the largest hospital remaining in Idlib. So Dr. Zahar, the floor is yours.
Thank you very much, Kat, for the nice introduction. And I'm humbled to be among this distinguished group of speakers to shed some light on the COVID pandemic in my homeland, Syria. And of course, we have now understand more about this virus that has been attacking different populations, sometimes differently, but there's some uniformity also in this virus. Of course, I practice in Chicago, and we have more patients in the United States than any other country compared to our population. Unfortunately, we had more deaths in the United States than any other country. We represent 4% of the world's population. We had 20% of the world death related to COVID. Syria, though, is unique and it's complex. And sometimes we look at these countries as uniform in terms of the COVID spreading and response, but Syria is distinguished or unique because of several things. One of them is what the Kat has mentioned, which is the war for the past 9 years that left many people displaced. Half of the population have been displaced inside Syria and outside Syria. There's about 6 million Syrian refugees in surrounding countries, Lebanon, Jordan, Turkey, of course, and Iraq and Egypt and other countries. You have shortage of healthcare providers. At one point, 50% of healthcare providers have fled Syria because of the war, because of the targeting of hospitals and healthcare providers, according to the WHO. Some areas have huge shortage of healthcare providers compared to others. So, for example, the Northwest has much more shortage in healthcare providers compared to the rest of Syria, about 0.14 physician per 1,000 population in Northwest Syria compared to about 1.5 physician per 1,000. So you have more 10 times less shortage of healthcare provider in Northwest Syria compared to the rest of Syria. But even for government-controlled areas, if you look at the map of Syria, we have 4 distinct areas in Syria right now in terms of healthcare systems. You have the government-controlled areas, which is about 2/3 of Syria map. You have the northwest, you have the northeast, and you have also the some small part in the north of Syria, which is under control of Turkish-led groups. So we have 4 different healthcare systems in Syria right now, all of them dealing with COVID. In the government-controlled areas, there is a chronic shortage of specialists and also poor management of hospitals, even before the crisis. In a study that I co-authored in 2013, we compared healthcare system before and after the crisis. So even before the crisis, when the last pandemic of H1N1 influenza hit Syria, the mortality rate in Damascus, which is the best in terms of healthcare systems in the capital, of course, was 80% of patients who were admitted with H1N1 to ICUs in Damascus. In some areas like Aleppo and Hama was 100%. I mean, every patient who was admitted with H1N1 to the intensive care unit died, compared to 40% in the rest of the region. So there is poor management, poor systems, and shortage of certain technologies, especially related to ventilators and protocols to treat patients who are critically ill even before the crisis. And of course, you can expect these things to get worse even right now. So what is the condition of COVID in government-controlled area right now? I mean, if you look at the statistics, the official numbers are only 4,000 plus of people who were confirmed and 200 deaths. But if you talk with physicians in Syria, if you talk with people who are expert in these issues, they will tell you that the numbers are much higher than that, probably 100 times higher than the official numbers. Part of the problem is related to the low number of testing. We always talk about testing in the United States and that we need to increase testings. So just for the sake of comparison, the last number I was able to get to in government-controlled areas that we were able, or Syria was doing 300 tests of COVID every day in 6 labs, 300 only a day. So far, Syria has said that, the Syrian government said that they've done 35,000 tests from the beginning of the pandemic. Now let's compare that to the surrounding countries that have their own COVID pandemic right now. Lebanon is doing about 12,000 tests every day compared to Syria's 300 tests. And Lebanon has much smaller population. Lebanon has a population of 5 million, Syria has a population of 20 million. Jordan in the south is doing about 16,000 tests a day compared to 300 tests a day of Syria. So many of the people who have COVID, of course, are not being tested in Syria. That means the numbers that you are seeing is very skewed, underrepresenting of the numbers. Another number that we have to look at is the number of healthcare providers who died with COVID in Syria. And according to the Union of Health in Syria, based in Damascus, there is 61 physicians up to last month who died in Syria because of COVID. 61. And let's not remember that the official number of deaths in Syria is 200. So 61 physicians died of COVID, according to the union, the healthcare union in Syria, is a huge number. If we extrapolate this number to the total number of deaths in other countries, in Italy, for example, we had 30,000 people who died, 200 physicians. So for every 100, for every one physician, you have about 3,000 people who died. If we can extrapolate that to Syria, we're going to end up with a number of about 10,000 deaths in Syria, not the 200 that the government has mentioned. Some of the local healthcare leaders in Syria, for example, the dean of medical school mentioned that his estimate is about 110,000 cases confirmed in Damascus area only. Many other authorities have mentioned much higher number than the official numbers. But clearly that's related to the lack of testing. In terms of management and in terms of the policies of the government to contain the pandemic, early in the crisis, there were some measurements that was in March and April that were implemented with a little bit about, following by the population for several reasons. The lack of trust of the government, the spreading of conspiracy theories, the stigmata of patients who had COVID. So many of the population did not want to let others know that they have COVID patients among them. So people did not even go to the hospital to be treated. And that led to this kind of apathy related to COVID in Syria among the population. When this second surge hit Syria, you continue to hear these kind of unconfirmed rumors that COVID in Syria is mild, it's only GI problem. For some reason, Syrians are immune to COVID, and Syria is unique, and that the government has done everything to contain the COVID and successful. So all kinds of these misconceptions that are not based on reality were there. And that led to, when the government tried to implement some social distancing and wearing masks and things like that, the population did not follow on these issues. There was a huge shortage of PPEs. So physicians were asked to buy their own PPEs, especially early during the crisis and in the last couple of months. And that led to higher number of physicians who were infected with COVID, and also higher number of physicians who died of COVID, and also the reluctance of some physicians or many physicians to treat patients with COVID. Private hospitals early in the crisis closed their doors to COVID patients because they did not want to infect the rest of the patients. And only 2 or 3 designated hospitals in every major urban areas were designated for COVID. That means if you're a COVID patient and you have shortness of breath, or you feel dizzy because of the COVID pneumonia, and you want to go to the nearest hospital, they will close the door to you and they will force you to go to other hospitals. For example, in Damascus, there were only 2 hospitals designated for COVID, and they had a long line of patients in the emergency room. Many of the patients died in the emergency room, and the patients did not have capacity to treat all of these patients who flooded the hospitals. And that increased, of course, the number of deaths because hospitals were not equipped to accommodate the surge. Many of the patients were treated in Syria, in the government-controlled areas at their homes, including purchasing oxygen concentrators and oxygen canisters, including purchasing ventilators. And this is the only country that I've heard that patients needed to purchase their oxygen and ventilators and to be treated at home because hospitals are not accommodating these patients. And 8 out of 10 persons in Syria below poverty line. The oxygen concentrator cost about 700,000 Syrian pounds. Not many people have that number. And so that many people died without being treated, suffocated to death inside their homes. So the situation of COVID in Syria is catastrophic. No one knows really what are the real numbers. The official numbers are only the tip of the iceberg. It can get worse if, especially with the opening of the schools right now and the crowding of the schools, the apathy among the population and the lack trust of the government. And just to give you one last example, that the president of Syria had a long speech just a couple of months ago, about 4 weeks ago, actually, in front of the parliament, 2-hour speech about the State of the Union, and he did not mention COVID even one time. Thank you, Kat.
Great. Thank you so much, Dr. Zahar. I know that all of those watching and listening appreciate very much hearing those really harrowing accounts from inside of Syria. Our next speaker is Dr. Nasser Al-Mahawish, and he is the surveillance coordinator of the Early Warning Alert and Response Network, EWARN. He is a graduate of Aleppo University, specializing in general surgery, and has a master's of public health. He has worked as the surveillance coordinator of EWARN, which is a division of the Assistance Coordination Unit, since 2015. And now EWARN is in charge of surveillance with the COVID-19 task force for Northwest Syria. And Dr. Nasser is an active member of that task force. So I am about to screen share, but over to you, Dr. Nasser.
Thanks, Kat, and thanks for MidGlobal for allowing us this opportunity to speak about this situation. And the situation in Northwest Syria has been developing rapidly in the last month, and since the beginning of the outbreak in China, the situation has been monitored by the globe, not just by certain entities, and everyone was looking about the international spread and the spread out of the borders of China from that time. From our side, we are included because we knew that the situation in Syria will not handle that properly, especially in the areas out of regime control, which we know more about. We know that the whole situation and the whole infrastructure is in devastated situation, but we need to be more focused on the areas where we can do anything to help the civilians there. As you can see from the first slide, if we skip to it, with the development of the situation, we can divide it to 2 phases. The first phase would be the one before the detection of the first case and the confirmation of it, and what follows after that. From the beginning, we tried to open the communication channels with everyone, trying to get the best that we can do. And through the health cluster and WHO office in Gaziantep, the establishment of the task force was a good point to start this, because having a coordination body between all the actors will allow the proper usage of the available resources and to identify the gaps properly, not with everyone acting on their own. And through that, multiple partners with their specialties were included, and each one of them focused on 1 or 2 pillars under this out of 8 pillars, including from surveillance lab, case management, IPC, risk communication, logistics, and the coordination itself. For example, SAMS, with their experience in the ICU and the case management, were involved in this. Other partners like SRD, like Awesome, with the community isolation centers, SEMA, Banafsaj as a national NGO. So everyone with their expertise were involved in this, including to the donors, of course, to make sure that the resources are available to fund those activities. I'll talk in general and focus mainly on surveillance, because from the first moment we tried to establish the base ground for this activity. Without detecting the cases, without detecting the spread of the virus, you cannot target your efforts. That's why we started with preparing the tools for this, from the data collection tool, data analysis, the basic ones for it, to the training for the lab, and to enhance the capacity of the lab, and to modify the already existing acute respiratory illness surveillance file to include COVID with it, because this is new. Everyone was trying to learn what's in that, how to deal with it. And we were included in this group of people. Recruitment of staff, increasing the human resources and everything, until we reached the level that, and we were lucky actually, if I may say this, that the detection of the virus and the circulation of the virus was a little bit later than we anticipated at the beginning, especially with the closure of the borders and having Northwest Syria and somehow isolated from the surroundings, from Turkey and cross-line from the regime-held areas. But the inevitable will happen, of course, and at the beginning of July, the first couple of weeks, the first identified case and the worst case scenario that we were afraid of happened, and one of the healthcare providers was the index case. A cluster happened. We were lucky also, and the organization of the activity to contain this cluster was somehow good, according and based on the available resources, to a moment that I can say that the last 4 cases from this cluster had 0 contacts, which is a good sign of the quarantine and the isolation activities conducted for that. But a second cluster happened, a third cluster happened, and now we are on the community transmission scenario. Therefore, we try to enhance more. We included more high-risk groups, more activities targeting the IPC measures at the health facilities, trying to push for the purchase of the ICU equipment, the ventilators and everything, although delayed, but it happened, expanding the lab network from the field and upgrading the already existing labs for EWARN in some areas to cover more areas geographically, and thus increasing the testing capacity, and at the same time minimizing the transportation time for the specimens to ensure the quality of the collected specimens, and trying to reach at least a minimum of 500, 600 specimens tested per day with our limited capacity and limited human resources, even training staff at the health facilities, specific ones, to have a decentralization of the sample collection in the field. The number of the cases was slower in that period of time, but with more areas included. Unfortunately, the spike happened, and that was also expected, and Hazem can elaborate more about this in his session. And September was the worst since the detection of the first case. The severity of the cases also, we noticed that it started to increase with more moderate and severe cases, and cases needed admission in the ICU started as anticipated and as we saw in other countries. With all this in our heads and with all this in the field, we know that in the future we should try to increase more and more. It's about testing, 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 and testing. So how we can do that? Through training of the healthcare providers in the field, through expanding the lab network, and maybe in the future as a way to look how the vaccine will be implemented in the field. We cannot wait till the last moment to see that, okay, yeah, we have vaccine, what should we do now? So all those are plans for the future. In the next slide, if you may, we can see just simply the changes that we noticed. Between July and August, with only 107 confirmed cases, and the distribution of them is all over Northwest Syria. And you can see that in September only, the first 30 days, and we're still, this number will increase, more than 990 cases confirmed already. And this is not all the cases, because we are missing cases for sure. And I will talk about this and the challenges in the next slide. So looking at this development, we can see how hard it is, especially that nearly 30% of the confirmed cases are from healthcare providers, including those working at the health facility level. This is a dilemma. This is a big problem for us because we know that we need to protect those guys and they need to follow the IPC measures. At the same time, you cannot afford to keep them in quarantine and isolation all the time. And this is something that we see in the field with some facilities with a first suspected case, they close, some of them for 14 days. So the cut of this service is very critical. Challenges wise, we see the limitation of the context that we are working with multiple controlling forces. And as Dr. Zahir mentioned, we have at least 4 health systems acting in Syria as a whole, each one with their own agenda, with their own practices, with their own ideas and ideologies to work with. The limitation of the access for our staff. Some of the facilities may refuse to allow us to conduct our activities there. It needs to be negotiated each and every time to allow this, because this means that we are missing more cases. The IDP movement and the population displacement, and this will make you either lose more cases and on top of that, more spread of the virus. Looking at us and the capacity for us and for our partners, the lab capacity needs to be enhanced, and this is a huge challenge because we started at the beginning with 1 device, 1 specialist, and 1 technician. They couldn't run more than 2 runs, so this is the max for them was 180 specimens tested per day. And looking at the logistic-related issues, sometimes it was less than 50 specimens per day to be tested. So with the enhancement, we hope that it will get better. The technical support and the overwhelming of the staff in the field, our staff and other staff. We have shortage in healthcare providers in general, doctors, nurses, technicians, and everything. And having those guys focusing on one aspect will means that they are neglecting other parts and how to deal with it. And if they got infected, what to do after that. So this needs to be addressed. The tools for all, the coordination between all pillars, through those tools, through robust tools that you can use to know that the outcome and the fate of the case, how to do it. You cannot just go by phone for each and every case, especially with the increasing number. Us being in Turkey, our field staff in the field, and I'm talking about all pillars, not just the surveillance, is also an issue when we look at it. And the global scarcity of the PPEs and how to manage it. Just to mention, from our side, to purchase a few thousand N95 masks, we had to wait for a similar mask, of course, the K95, to come from China. We had to wait for more than 1 month for it. So imagine if you want to provide proper amounts for all the healthcare providers in the field. And again, having the first case with a healthcare provider and the fear now happening between other medical staff about what if I got infected? Will I be cut off from my work in this place? How can I do? So we saw some cases where they try to hide their manifestation to avoid being sent to home. This leads us to the community and the stigma that Dr. Zahir also mentioned about the stigmatization of the patients. And for them, it's just some kind of a plague that they want to hide from others and not to show other people that they have COVID and denial. And again, this happened in the field with people trying to deny completely that they have any kind of fever, any kind of respiratory manifestations, which leads to refusals for sampling for those patients for different reasons, and which makes less identified cases in the field. And as I said, with the delay of the confirmation of the first case, people started to feel that, okay, what's the point of wearing a mask, of physical distancing, of lockdowns? Nothing is happening, and the fatigue happened, and the psychological effect of all this also hit very hard. On the coordination level, the weak and the absence of governance and good governance in the field is a huge issue because you do not have accountability. When you go to a health facility, they say, okay, you are an NGO, you are paid, you are getting money, why would I help you? What would I gain in return? This needs to be addressed hugely. And with all the multiple actors in the field, it makes it even more difficult for that. From the beginning also, with the implementation of the different pillars in the field, we noticed that the delay in purchase, the delay in launching, the community isolation centers and the case management hospitals led to a bad reputation in the field, which reflected eventually on the trust from the community about this issue and how to communicate this and increase the awareness between the community. And of course, the funds. When you have the available funds and the plans for the planning for 140 millions, for example, and you find that you have only 40 millions to implement, this will make some delays. And if the cases started to increase more and more, it will be more and more devastating in the field. This is all from my side. I wanted to be brief. Thanks again, and back to you, Kat. This slide just for the thank you.
Thank you so much, Dr. Nasser. And I know that we already are getting some questions about the Northwest, so I'm eager to hear more from you in the Q&A. And now on to Hazem Rihawi, who is the Senior Programs Manager for the American Relief Coalition for Syria, or ARCS, which is a coalition of 10 Syrian diaspora-led humanitarian organizations that provide multi-sector relief inside of Syria. He is a pharmacist who also graduated from Aleppo University in Syria and has a Master's of Public Health from the Johns Hopkins Bloomberg School of Public Health. Hazem has 9 years of progressive work in the pharmaceutical industry in Syria and over 6 years of extensive leadership experience in humanitarian responses, focusing on health and coordination. He was previously the co-lead of the health cluster serving Northern Syria, the director of the NGO Forum serving Syria, and the health cluster coordinator for Somalia. Over the last 6 months, Hazem, along with Dr. Nasser, has been conducting research with the COVID Modeling Consortium as part of the Northwest Syria modeling team, which is what he will be focusing on today. So over to you, Hazem.
Thank you, Kat, and thank you, Nasser, and Dr. Zahir and MedGlobal for inviting me. What Nasser has explained and about the spread of COVID-19 has been worrying us since long. And remembering the past webinar, we talked about a starting study that we did in May. And later on, we were contacted by the COMO consortium. And we started this small team that is doing modeling for northwest of Syria. So our colleagues, Manar, Omar, Wael, Hani, and Nasser, and Dr. Aula Abbar, and Dr. Mahmoud Hani were all part of this team. Next slide, please. So this COMO consortium is a consortium that has started as a collaboration between University of Oxford and Cornell University. With the idea of providing a model to allow policymakers to make the best decisions based on what would be anticipated of the progress of COVID-19. Next slide, please. As you can see from this model, this has been done with 45 countries around the world. There are lots of teams, and the Northwest Syria is just one of these teams. And we are trying to feed in the policy making related to COVID-19 response. Next slide, please. So this COMO model it's a mathematical model that relies on age structure. So as we have seen, COVID-19 is disproportionately affecting per age. So this COMO is just when we think about the modeling in itself, it's structured as an age, and then we look at it as a susceptible, exposed, infected, and then removed system. Next slide, please. I will go quickly through this. Also, next slide, please. Okay. As with any model, I mean, it must be anticipated that this model has its own limitations, and we are trying our best to build on the data that we have. And we are also, like we said, we are just part of one team among a whole world, and we are building up and changing the formula and the equations time and again. Next slide, please. So for this model in Northwest Syria, as many of you know, the data is always a struggle for us to be able to see and to build up any kind of modeling. So we relied heavily on available data. So for demographic, we relied on the Humanitarian Needs Assessment Program. For cases, it was the E1, of course. And then for the health system, it was the Health Information System for Northwest of Syria related to Idlib Health Directorate. And for interventions, it were our colleagues, Relief Experts Association. Next slide, please. So as with any model, there are lots of parameters that we relied on to be able to estimate what would be the projection, the epi curve that would happen in Northwest of Syria. Of course, that will be available for any questions regarding this, but I'll try to skip forward quickly. Can you, next slide, please. So in our model, we relied heavily on the non-pharmaceutical interventions based on the 4 categories that we see that are applicable in Northwest of Syria. So first of all, in Northwest of Syria is heavily locked down. There's the movement inside and outside is really minimal in comparison to other parts of the world. Secondly, mask wearing. So we studied also the effects of mask wearing, among others. The third thing was the hand washing activities and the way we will be able to push the community to take over on this. And then later on, the schools lockdown. So whether schools will be shut and how to look at it from this side. So the first, this is the baseline scenario. So we created different scenarios with different interventions between opening schools and closing schools. This, of course, we relied on the data coming from the ACU. And then we, as an experts, we estimated what would be applicable in the Northwest. Next slide, please. Next. Go ahead. So this is our estimation based on this model. As you can see, we thought about it in 5 different models. So first of all, the baseline effectively is saying that we will not, as a community, there will be very minimal intervention, and we will see how it will go until the end of the year. The second would be a more aggressive interventions in terms of mask wearing, hand hygiene, and of course we have the lockdowns. The third is with the school opening on September 15th, as is the school normally open. High disruption mean that we will be aggressive and we'll have enormous lockdowns. People are wearing masks. We have good practice of hygiene. And the second is that the effects of of all of these activities, but with the school reopening. As you can see here, our estimation, and this is just a projection which will help, hopefully will help the policymakers when thinking about this, is that the peak may happen in mid-November if minimal intervention will happen. But if we are able to increase a little bit, we will see a better control of the disease with a peak coming by the end of December. And as you can see from these numbers. Next slide, please. Next, please. So the number of deaths, we are estimated in the baseline to be 2,000 deaths by the end of this year. Of course, it's being affected heavily by the age grouping. So because it's a younger generation that we have, hopefully we'll be able to control this earlier, but it needs a lot of work from the civil society. Next, please. Next slide, please. Next slide. Yeah, so this is here, as you can see. Unfortunately, the capacity of our intervention, health intervention, is very minimal. The available hospital beds that are available in the Northwest that will be available for COVID-19 is around 75. And as you can see, we will require a huge amount of health intervention if we are allowed the disease uncontrolled and going outside. We will not be able to control it in one way or another. So there is a huge, this is one of the things that unfortunately may happen if this, and remembering that this is a conflict-ridden zone with hospitals being occupied 90%, all the year. Next slide, please. The key findings, as you can see here, as we have shown you that we have 4 scenarios here. 6 interventions have been looked at, and as we said, the heavier the intervention, the curve will be flattened, and we will be able to control it. Next slide, please. As we see, I mean, putting in mind when we look at this, we should all be very cognizant of the limitations of this model. Of course, this model relies heavily on age structure, and it doesn't take into consideration the population density, the poor economic situation, and the living conditions of the population. We on the northwest of Syria, there's no mortality registration, or it is very, very minimal. Even in northwest of Syria, there are the multiple policymakers, which will lead to fragmented health governance. We've excluded some NPIs during our model, which could be included later on. And then we rely, as Nasser said, on testing, and this is unfortunately is limited to now. Thank you. I mean, that's all from our side. This is acknowledgement to everyone. Thank you.
Thank you so much, Hazem, for presenting that really important research. And our final speaker on the webinar will be Tim Young, who is the Northeast Syria Forum Emergency Coordinator. Since March, he has been exclusively supporting COVID-19 preparedness and response efforts. In this role, Tim supports the coordination of the emergency response to COVID-19 among humanitarian actors, and leads engagement and representation with other key stakeholders. Previously, Tim was responsible for intersector coordination for the Northeast Syria, having previously been working with OCHA, supporting the whole of Syria coordination. So over to you, Tim.
Thanks, Kat, and thanks again for the chance to participate in this. I think the first thing to say really is that the experience in NES, there are definitely some parallels with what some of the other speakers have mentioned, but I also think some very distinct issues which I hope come out in my presentation now. What I want to focus on is really 5 or 6 key issues we're facing in NES at the moment, really highlighting those key challenges, gaps, and priorities in the response as we currently see them. Before I go into those 5 or 6 key issues, maybe just to ensure everyone's on the same page, I'll just give a brief update on what the spread of COVID-19 looks like in NES at the moment. So since the 23rd of July, we've had 1,670 confirmed cases of COVID-19 in NES, and this includes 67 deaths and 437 confirmed recoveries as of the 30th of September. So of these 1,670 confirmed cases, we've had about 15% which have been confirmed among health workers. We obviously think this is a significant underestimation and that there is a lot of underreporting, particularly among health workers. To give you an idea of kind of the current scale of transmission, in terms of, again, the confirmed cases, the 7 of cases as of yesterday was 47 cases. It should be noted that positivity rate is extremely high, so about 35% of all samples which we've tested have returned positive. And this is obviously an indication of significant under-testing, that we're not really sampling a big enough proportion of the population to accurately reflect the prevalence of the infection among the community. I should also note that we did have 6 isolated cases back in April, but no further confirmed cases between April and the 23rd of July. As always, and as some of the other speakers have mentioned as well, we do always caveat that the confirmed cases is just a small fraction of the actual number of COVID cases in NES. And this is unlikely to give an accurate reflection of either the total scale of transmission or even the geographic scope of transmission in NES. And this is for a variety of reasons, which I'll get into in a minute, related to low levels of case detection capacity and limited testing capacity in NES. So really to highlight on some of these 5 or 6 key issues, which I think are very pertinent to the challenges we're facing in NES at the moment. The first, as some other speakers have mentioned as well, is really around that community engagement and the risk communication side. I think we found that there's very low levels of risk perception among the community. And and we've seen minimal adherence to basic personal preventative measures. Assessments and our own experience in NES has really indicated a drop-off in that adherence to some of the basic hygiene measures. We do have a mandated directive from the self-administration for NES, which mandates the use of face coverings in public spaces. But unfortunately, this has not been adhered to and it's not been enforced. So again, very low adherence to any of these basic personal preventative measures at the moment. So, you know, why are the levels of risk perception so low in NES? I think there's a few factors which shape this. I think first is the experience over the past few months and the experience over the last 9 years. I think the past few months, there has been a feeling that NES has been quite fortunate, that NES has not been affected by COVID-19. And again, like some of the other speakers were mentioning, that the population here has in some ways been protected from virus, which is obviously not the case. And I think some rumors around this, that the strain of the virus in NES is less virulent than in other places, has really perpetuated this as well. I also think that we can't, the reality of the last 9 years can't be lost on people's reactions either. You know, people have lived under ISIS. We have a huge number of displaced people who've gone through significant hardship. They're now facing a socio-economic crisis, and COVID is one more factor on top of a huge number of hardships which they face. So I think we have to bear that in mind. But I also think that people in positions of authority and key influences in society also set a precedent. And I think what we've seen in NES is that there's been skepticism among key administration officials, among key health officials, among other key influences around some of the personal preventative measures and around the level of risk presented by COVID-19. So I feel that we haven't been able to mobilize the population because we haven't set that example at the highest level. And again, I think the example of, you know, one of the civil councils this week has been suggesting that in the area they control, the strain of the virus is very mild, is not a risk, that people can go about their normal lives. That does not really help in trying to increase uptake of some of these personal preventative measures. Related to this, we also see no enforcement in this. So at the moment, there are essentially no movement restrictions in place or no lockdown measures in place. And I think that has a key impact on people's perception of risk. What we have seen is that in Hasake Governorate in particular, there was a localized lockdown from the end of July to the end of August. And in that period, we actually saw a significant uptake in the proportion of the population who were wearing face masks. So again, not perfect, but we were seeing for some time, over 50% of people on average in Hasake would wear face masks. As soon as these local restrictions were discontinued, adherence decreased. So now the vast majority of people you'll see will not have a face mask. So I think the decisions and the implicit messages sent by the authorities through the measures they're implementing obviously has an impact on people's perception of the level of risk. And that's something I think we need to bear in mind, and we need to try and we need to try and shape in terms of the policy discussion. And I think just the last point really on risk communication is around the risk communication itself. As I mentioned at the start, the scale of transmission we're seeing in terms of the daily confirmed cases does not show an exponential increase in cases. It's really plateaued since the 23rd of July with no significant shifts in transmission, although we are starting to see an increase in areas in the west of NES like Raqqa and Tabqa. And again, I think this kind of lack of nuance to the risk communication and some of the daily announcements which are made to the authorities just perpetuate this understanding and this mindset that things are not that bad. And I think the message has not got through that things can get a lot worse, that there is a huge scale of undetected transmission which is not reflected in these confirmed cases. Secondly, I just want to touch on this issue of low levels of case detection, which we're facing in NES. We do have a hotline mechanism, which is the basically underpins our surveillance system in NES and the alert and referral network. But there's been quite a low level of detection up to now. So we're not even getting the sample size to really be able to scale up testing. And I think this is for a few reasons. I think as other speakers have mentioned, we understand from the community that social stigma continues to be a significant issue and a disincentive sometimes to reporting symptoms. For instance, you know, people tell us in some of our community focus group discussions and engagements that they don't ring the hotline because, you know, they don't want the neighbors to see an ambulance. They don't want the neighbors to see health workers dressed in full personal protective equipment come into their house, and they don't want the rumor to get out that they might have the virus. So this has been an issue which has contributed to low levels of reporting. On top of this, we've had a unique challenge in NES that we had widespread use of rapid diagnostic tests for a long time by the self-administration. And these rapid diagnostic tests were not testing for COVID, they were testing for damage in the lung tissues. So they very rarely returned positive results. And even when they did, it was not an indication that it was necessarily COVID. It could be lung cancer, could be tuberculosis, or a range of other conditions as well. And these rapid diagnostic tests were kind of used as a primary layer or a primary tool for diagnosis in some parts of NES. So people would not be referred for a PCR test unless they tested positive with a rapid diagnostic test, which is extremely unlikely. So we had a situation, for instance, where in Membridge, we had no samples collected via the self-administration surveillance and referral system between the 23rd of July and I think mid-September, because the rapid diagnostic tests were being used as its primary tool of diagnosis. In addition, we're still seeing that many people are going to the health facilities rather than contacting the hotline which has been established. And at health facilities, we're finding that there are a few recurrent issues which are preventing the accurate diagnosis of COVID cases. In some instances, it seems that there is a poor application of the case definition still, and a lot of misdiagnosis of cases. We're also finding that in many healthcare facilities, doctors are requiring a chest x-ray before they will refer an individual for a test. So setting, again, quite a high threshold for testing. And then we're also finding that even where a doctor does suspect COVID, they don't always report to the operations desk, which manages the sample collection process. And that's in part because they have a financial incentive not to. There's obviously a lot of socioeconomic hardship at the moment, and there's an understandable fear that their facilities might be closed down for disinfection, that they might lose patients. So this is anecdotally something which has been reported to us as a factor which is contributing to low case detection. And as the last factor here, I would just highlight the capacity of the rapid response teams themselves. We're finding in a lot of locations, Deir ez-Zor, Raqqa, and Tabqa in particular, there's not enough rapid response team capacity. In some areas, just one rapid response team per district. And then in a lot of locations, the personnel of the rapid response team are double hatting as another function as well. So again, not a lot of sample collection and case investigation capacity. Thirdly, and I'm wary of time here, so I'll try and rush through this a little bit, but we have some clear constraints when it comes to testing capacity in NES. So from May 2020, the self-administration were able to acquire PCR testing capacity. We currently have 2 PCR machines installed in one lab in Qamishli, which basically oversees a centralized approach to testing in the Northeast. There are a further 6 PCR machines which are in stock, but they're not currently installed. At the moment, we're testing on average around 120 samples per day, and as mentioned, a very high positive return rate. While case detection is obviously an issue which is contributing to the low number of samples we're testing, the reality is that we do face some very clear resource constraints on our capacity to scale up testing. The stocks at the moment, in terms of the diagnostic supplies, are extremely low, and we do face a very real risk of a stock out and no testing capacity in the next 3 to 4 months at current levels of testing if we do not receive additional stocks. So key gaps are obviously in the PCR testing kits themselves, RNA extraction kits, filter tips, microtubes, the personal protective equipment. And in NES as well, we obviously face some very specific constraints on our supply capacity. So we have no additional pipeline in place at the moment to replenish these stocks. So as NES NGOs, we're looking at opportunities to procure some of these items, but no NGO has the capacity to procure at the scale required. And there are obviously a lot of logistical constraints, which we still face to get these supplies into NES. As a fourth issue, I'd just like to highlight infection prevention and control among health workers. So as other speakers mentioned, we do face significant transmission among health workers and at health facilities in NES at the moment. As of today, in NGO-supported healthcare facilities, we estimate that roughly 200 health workers are currently either in self-isolation or quarantine, and close to 10 health facilities are closed or have had to close down some sections of their health centers, given the transmission they've experienced. So some of the specific challenges we face around IPC are firstly the acute shortages we face of health workers. And this has contributed to a situation where we have always had health workers working in multiple health facilities and working under multiple healthcare providers. So we've made a conscious effort and a concerted effort to really coordinate the movement of health workers and to ensure that there is some limitations in that movement and work between different health centers. But given the different healthcare providers in NES, from the self-administration, the government of Syria, NES NGO partners, the WHO and their implementing partners, private facilities as well, this is extremely difficult and has required lots of negotiations. So we still see lots of movement between facilities. Secondly, we're still seeing, as I mentioned before, a high number of people come to health centers themselves to report symptoms rather than go through the recommended modality, which is the hotline. So this is obviously contributing to contamination in health facilities, particularly given that in a lot of them, especially some of the main self-administration supported hospitals, there are not yet adequate triage and screening procedures in place at the entrance. We do also hear, similar to in other locations, about significant shortages in personal protective equipment. NGOs are not facing a critical gap, but even for NGOs, in a recent survey we did, we found that of 64 of the roughly 100 NGO-supported health facilities in NES, there were gaps in current stocks of PPE reported for the next 3 or 4 months, i.e. until the end of the year. And of course, as I've already mentioned, we face some very specific logistical constraints in NES. We also hear in some non-humanitarian supported health facilities of more critical gaps, of instances where disposable PPE is being reused, where it's being washed, or in some cases where there are rules not to use PPE unless a patient has been confirmed as having COVID. So these all contribute to this increased risk of transmission among health workers. And we also, face this reality that given the shortage of health workers we face, that we could have a situation of health system collapse here in NES. The last issue I'd like to raise around IPC is really about, complacency and compliance issues. And it's quite a difficult discussion to have. But I think at this point in time, we can't say that a lack of adherence to IPC measures in health facilities is for a lack of training. These trainings have been provided in depth multiple times over the last few months. So I think what we're discussing as NGOs, as other healthcare providers in NES, is what additional steps can we take to ensure compliance among our staff? And that's quite a difficult discussion to have, but I think one which is necessary at this moment. A fifth issue, I just have 2 more points I'd like to touch on, is really around case management capacity. So we're under no illusions that whatever we do, we are never going to have enough beds to respond to the likely surge in hospitalizations we will experience over the next few months. We have huge gaps in capacity at the moment. So we have 23 dedicated isolation facilities for COVID cases planned, Of these, currently 10 are operational or partially operational. In terms of the number of beds, this translates into having 384 beds for moderate and severe cases, which are currently available, and 59 beds for ICU, so for critical cases, which are currently available, not all with ventilator, I should add. If we apply a minimum standard of, let's say, 8 beds per 10,000 persons for the moderate to severe cases, we face a current gap of 818 beds. So that's a huge gap. For ICU, applying a minimum standard of 2 ICU beds per 10,000 persons, we estimate we have a gap of about 236 beds. So obviously there's issues here with quantity and capacity, but I think quality is a huge issue as well. And I think just providing these numbers to you can be a little bit of a diversion from some of the real issues we face. Just because we have beds which are currently operational does not mean that the quality of care is necessarily assured. We have issues in terms of the organization and layout of some of the facilities, the IPC controls. And we also still have a perception, especially for critical care and ICUs, that an ICU bed is, or ICU capacity is, you know, a bed and a ventilator. And this is still very concerning. We have lots of concerns over ventilation and around capacity to support ventilation. Although we've had a very small sample size of patients who've been hospitalized so far and ventilated, the reality is that all patients who have been ventilated in NES up to this point have died. So I think the focus for us has to be to ensure that we don't get to the point where we need to ventilate patients. So really developing a clinical protocol which focuses on this component is really critical. So in case management, I think, you know, some of the key gaps we face is really around, you know, that specialized training for the treatment of moderate severe cases and critical cases. Last, just very quickly, I wanted to touch on the coordination challenges which we face in NES. NES is a very fragmented and decentralized system of governance, and I think that's presented some unique challenges in implementing a coherent approach to COVID-19. Just because something is agreed by the Department of Health at the central level of the self-administration does not mean that that trickles down to the local level and ensures kind of a coherent approach implemented by all the civil councils and the cantons across NES. And we've had specific examples where this has created a divergence of approach, whether it be in the operations desk and referral system, the testing approaches, or even the case management approach itself. So on that note, I will stop there and hand back to Kat, but of course, happy to answer some questions. Over from me.
Thank you. Thank you very much, Tim. I just want to acknowledge that we're slightly over time, but I think that those details were incredibly important and ones that we don't often get, particularly from Northeast Syria. So I really do want to thank you. I am conscious of time. For those listening in, I think we're going to go for only 10 more minutes just to get a few questions in. And I'm going to start with a list of just 3 questions, and if all of the panelists can go through them one by one, that would be fantastic. This has been really critical information to hear from the different areas of Syria. And I'd also love to specifically hear what you've been hearing from health workers inside of Syria themselves who are treating COVID patients. How are they feeling? What their key needs are? If there's specific experiences or instances that they've described to you. So that's question 1. Question 2 that I would love to know, and particularly curious from you, Tim, as we all know, in July of this year, the UN Security Council Resolution 2533 was adopted, and that was reauthorizing cross-border assistance into Syria. But it was only renewing the Bab al-Hawa border crossing, closing the Bab al-Salam crossing, and also not reauthorizing the crossing for Al-Yarubiyah. And I'm curious to know if you have any insights as to the impact of that change so far, or perceived impact that might come in the future. And then finally, a lot of people who are listening into this webinar are in the policy space. And I would love to hear from all of you about just the few top needs or advocacy asks that you would have for either the US government or other global stakeholders. So maybe if we can quickly begin with you, Tim, and then go to Hazem and then Dr. Nasser.
Sure, I'll try and keep my answers quite brief. So in response to your first question, what are we hearing from health workers who have been treating COVID patients? Just really 2 points to note here. I think the first thing is that we've strangely had very low levels of hospitalization in NES, and this is a concern. You know, we are concerned that people are dying in their homes or not being recorded as COVID cases. We do expect this to pick up. But we're really not seeing this demand on hospitals yet, which we've seen in other parts of the country. But I think one message which has been conveyed quite clearly from healthcare workers is that people are coming to hospital far too late. That, you know, quite often it can be 10+ days after symptom onset. And at this stage, they are in a more severe condition. They're more likely to require ventilation potentially. And, you know, the chances of survival and like these kind of early interventions, which can mitigate deterioration in condition, are in some ways lost. And we're trying to rectify this. We're trying to ensure that, you know, the rapid response teams who respond to alerts are also doing a severity assessment, ensuring that people with comorbidities are also referred to hospital when they have symptoms, if that's bed availability. But this is a real frustration, I think, from some of the health workers at the moment. In response to your second question on what's the impact of the non-renewal, or I should say, you know, the reinstatement of the Security Council resolution for the Northeast. Yeah, I mean, the reality is for the Northeast that we lack predictable and viable supply chains, and the Yarabia crossing we were uniquely kind of dependent on for some health items. Some pharmaceuticals, but also some of the consumables as well. And given the global climate around COVID, supply shortages, and also the pandemic nationalism we've seen in some countries, which is understandable, but we've also experienced in KRI, this kind of informal cross-border supply chain, which we have, is even more difficult and less predictable than it was in the past. So we are being able to bring supplies in to NES, but it's not predictable. We have to negotiate individual shipments. There is no official directive from the KRI authorities or the Iraqi authorities, which prevents us from moving PPE and other medical items from KRI into NES. But at the same time, we have shipments regularly stopped and items which are taken out. We have to reduce quantities. We have to have more shipments. There are a lot of delays and logistical constraints. So I think in sum, to keep my answer quite brief, the impact of the UN Security Council resolution has been that, or the non-renewal or non-reinstatement, is that to have a predictable supply line in NES and a predictable pipeline, we do require multiple modalities, whether that's UN cross-border shipments under a Security Council resolution, whether that's NGO local procurement, whether that's NGO cross-border procurement, or whether that's cross-line assistance from Damascus. And we need this because we know that any one of these pipelines can break down. And this is a situation we faced at the moment. So we are having significant delays in some of the isolation centers. You know, some of the isolation centers, which we were hoping would be up and running by May, are not going to be up and running until November. And that's in large part due to some of the supply and logistics issues we faced. So I hope that kind of answers your question on the resolution. Over from me.
Great, thank you so much. And Hazem, if you have any comments about those questions.
I mean, I would leave the discussion about the Northwest to Nasser mostly because he's on the ground and will be able to answer better than I do. But at least from our side, our recommendation to the US government is to try to increase the funding, especially in the coming days, as we anticipate the peak going up. Till now, we anticipated a little bit earlier peak. at least the increase of the cases we anticipated probably was in August, but now we see that currently in September, as Nasser has mentioned. So definitely what we would encourage is that this is the time now to increase the funding and the support coming into the Northwest and the Northeast and all even government-controlled area to the UN agencies being based there, because we are seeing an increased number of cases that are affecting everywhere. And we would definitely try to push also on the civil society organizations to help us, to help the health staff in controlling the disease, because as we have seen and we have seen around the world, the health systems, even in developed countries, were struggling to be able to control this. And you can imagine in a conflict zone like Syria, it will be a further issue. So definitely we would require, and we are asking all stakeholders to just prepare themselves and help the health system build up to be able to control it, and not to allow increase of cases that will be just unbearable and uncontrolled in all territories in general. After 10 years of conflict, that will be a big issue. And in terms also in Northwest, we are very much cognizant of a probable and maybe escalation of violence, especially coming from the regimes. So that would be also a very worrying thing in these times where cases and a pandemic is currently ongoing inside Syria. So that will also be very, we are very worried about this. In addition to another public health threats that may affect Syria, especially with influenza H1N1 that may come, and also will add additional burden on this. But definitely, I mean, I would definitely listen to Nasser specifically, because he will be, E1 has been always at the forefront of responding and surveillance. So definitely Nasser will have better answers even.
Great. Then over to you, Dr. Nasser.
Yeah, actually, Tim hasn't covered lots of this topic, this issue. And from the feedback that we get directly from the healthcare providers in the field, our staff and those at the health facilities working with other partners, that the lack of PPEs for them, they need to feel protected. And without this, they will not be able to perform properly. And that's why we heard some incidents about patients just asked to leave the health facility the moment that they suspected that there could be COVID cases, because this fear and this stigma, and they don't, as I mentioned in my slides, that healthcare providers do not want to have COVID, not to lose work, not to lose their ability to perform at the health facility. This is one. And the second thing is related to some of the information about the isolation centers and the quarantine centers between the people, that it's not well equipped, it's not well prepared to host cases. And another thing about the healthcare provider is that with their need of security, not just and protection, not just from this, but also from possible airstrikes, from possible attacks, and how also to deal with this. It's all a mix, it's all messed up, and especially added to that, the fact that some healthcare providers, and considerable number in my opinion, are still not aware of the roles of each partner in the field. So they would come to us in E1, for example, asking for referral. And please provide us with a car or a vehicle to transport this patient to that place, although it's not our rule. We try our best to facilitate, but this is not an easy thing to do in the field with all the mess up and with all the chaos that we are facing at some areas. So that's why the role of community awareness and risk communication is very critical in this phase. Back to you, Kat.
Great. Thank you so much to you, Dr. Nasser, and Hazem and Tim and Dr. Zahir, who unfortunately had to go back to work at his hospital. I just wanted to see if anyone has 30 seconds of closing remarks to add. No?
I mean, just from my side, extremely quickly, just in terms of, key asks and priorities from our side, I think You know, I highlighted some of the key supply gaps we face. We face this real issue with diagnostic supplies and do fear that we will have no testing capacity come the end of the year. We need to find other viable pipelines to be able to provide PPE and other medical equipment for the isolation centers. And we also need the funding to continue at high levels into 2021 and 2022, when that kind of latent socioeconomic impact of COVID is likely to be most severe. So I think those are kind of the last few thoughts from my side.
Great. Well, I think that all three of your remarks really closed it out. I think that ending on the comments of funding being more critical than ever, and particularly what you highlighted, Dr. Nasser, about a lack of PPE for doctors being an acute challenge and one of the most critical to meet, is an important note to end on. So I want to thank our panelists so much for joining, and thank you so much for everyone who's attended this webinar. We will be posting it online, as well as clips of text from the panelists' comments. And one thing that we would love everyone to consider is to stay involved and up to date about the crisis in Syria. You can go to medglobal.org/Syria to learn more about what we're doing and support the urgent COVID-19 response right now. So thank you all so much for joining, and have a great rest of your day.
Thank you. Thank you, Kat.
Thanks. Take care.